protocols is there's a lot of education that happens in the doctor's office, talking about bowel preps, what to expect, etc. A lot of them have, they're actually finding that fasting is not, like they have better outcomes if they actually have a little carbohydrate drink 2 hours before surgery. We don't do that here, that freaks anesthesia out. It's very hard to get them on board with that, but they're finding, and they're special carbohydrates. It's not like a Gatorade, it's a special drink that's made for this. We don't have that here, you're not gonna see that here, but these are just some of the things that are taking place with these protocols across the country. We have a lot of goal-driven therapy. Sometimes we'll go pick up a patient and they've already got a liter in. Well, now they're saying we're supposed to only do a liter for the colorectal cases. The less is better for them. So it's, and then also we're going to decrease opioid use. That's a big deal. You're going to see that anesthesia is rapidly changing. Our whole approach to how we give anesthesia is really changing as far as no opioids, more regional, lots of pre-medications, because the opioids just, they have a lot of effects on the body, as you know, increased ileus, diet, they don't return, they don't want to get up. So anyway, moving on to the prompt protocol, now that you kind of know what ERAS is and how it's coming down the spout, prompt protocol is a type of ERAS protocol. And it came from MD Anderson, it was made by them, and it was for cancer patients undergoing colorectal surgery. And it can be used on anybody, but that's where it came from. Dr. Messick brought it over, and now I think Opperman and Yacobian are using it as well. And let's see, the basics of the protocol. For cancer patients, they didn't want them to have any opioids for reasons known. That increase in ileus, for a bowel patient to have an ileus, that's a 2-week stay in the hospital after surgery. If we can prevent that altogether, they get up, they go home, less cost, better patient satisfaction. So, and also there is a pathway, a cancer pathway associated with the mu receptor. So they don't want any opioids because it can actually cause cancer spread. They also don't want any volatile gases. It's no SIBO, no DES, none of that. So then what are we left with? What do we do? The surgeon will order specific medications, Neurontin, Tramadol, etc. They get these in the AOD, and they kick in usually by the time we pick the patient up. They're nice and relaxed, and that's kind of their Versed and pre-medication. They're really usually nice and calm. And they will continue to order those post-operatively as well. So, and then what we do in the OR is all drips. Everything is IV, unless we can use some nitrous oxide if it's open. But otherwise, no other gases are given. So we have 4 main drips. We have lidocaine, we have, which is just anesthetic. We have Dex, medetomidine,